Thank you again, Dr. Gina Sorton-Evan, for your nice introduction. I appreciate you and everyone for offering me this great opportunity to join this wonderful communication channel to introduce the recently released Oral Health Surveillance report by CDC in 2019. And as Dr. Gina Sorton-Evans mentioned, this report assessed trends in oral health status based on selected outcome measures in the past decade from the National Data Source, National Health and Nutrition Examination Survey. So today we will work through this report's main finding that children's oral health status is improving, but adults are lagging behind. So from the title, you can see that it's really exciting to see improvement in oral health status, but we can see challenges remain. So this slide just shows the outline of this presentation. So first, we will briefly discuss the background of NHANES, which this report is based on, and it's also a major oral health surveillance data source. We will then walk through the 2019 Oral Health Surveillance Report from its rationale, objectives, to findings and public health implications. So first, let's take a brief refreshment of NHANES. So NHANES is a population-based cross-sectional survey administered by CDC's National Center for Health Statistics, or NCHS, on an ongoing basis. NHANES data are representative of the civilian non-institutionalized U.S. population. Each year, about 5,000 people are surveyed. So NHANES has been used to monitor the oral health status and the nutritional status of children and adults of the nation, such as tracking national progress in key healthy people objectives on oral health. And NHANES is a unique data source, as it is the only national survey that includes physical examination, dental examination, laboratory and interview data. And this chart from left to the right outlines the history of NHANES and how it has evolved over time. So the first NHANES start from 1960 to 62, named as National Health Examination Survey, or NEHS. So from the left, you can see the first three surveys conducted in the 1960s focus on health topic areas in different populations. And since 1970s, nutritional status surveillance was introduced and combined with the National Health Examination Survey to form the National Health and Nutrition Examination Survey, or NHANES. And then since 1999, NHANES has been implemented continuously or annually with data release in 2-year cycles, such as 1999 to 2000 cycle and 2015 to 16 cycles. And oral health measures have been included in NHANES since the first survey, 1960 to 62, except NHANES 2, 1976 to 80. So CDC has published oral health surveillance summary reports based on NHANES through several channels. One channel is through the CDC Morbidity and Mortality Weekly Report, or MMWR, surveillance summary reports. And the screenshot on the left is the 2005 surveillance summary report through the MMWR and with the URL provided here. And another channel is through the NCHS Series 11 of the Vital and Health Statistical Reports. And through the Series 11 report website, you can locate all the historical NHANES report based on NHANES starting from 1960 to 62, the first survey. And the screenshot on the right is the Series 11 report published in 2007. And this screenshot is the most recent CDC's oral health surveillance report published in 2019 that we will discuss today, and the report is available on the CDC's oral health surveillance report website provided here. And through the NHANES website with its screenshot provided on the left, you can access a wealth of additional resources. For example, you can search topic areas in each survey cycles. As many of you know that NHANES is a complex sampling survey. So from this website, you can also learn NHANES survey design and analysis guidelines. You can also download data sets, data dictionary, questionnaires, examination protocols, and other supporting documents. And through the NHANES tutorials, data users can learn how to manage NHANES data sets, taking into account the complex survey design parameters in the analysis, and how to use software packages, especially its survey packages, such as SAS, Sudan, and Stata. You can also access other NHANES publications and products, such as data briefs. So now let's navigate this 2019 CDC's oral health surveillance report. So what is the rationale of this report? According to the Global Burden of Disease study, untreated dental caries has remained the most prevalent disease among over 300 diseases and injuries in nearly 200 countries from 1990 to 2016. Edentulism, or complete tooth loss, is one of the leading causes of years lived with disability. And CDC's 2019 oral health surveillance report built up on findings of earlier reports and is the first to include the most recent data from 2015 to 16 in assessing current levels and trends in oral health outcome since 1999 to 2004. And it covered period when major national initiatives and policies were implemented, such as the 2003 American Academy of Pediatrics recommendation on age for child's first dental visit, and the Oral Health Initiative launched by the Centers for Medicare and Medicaid Services in 2010. Furthermore, serving the ultimate goal of the national oral health surveillance, this report can help public health agencies, organizations, oral health programs, and healthcare providers, and also researchers inform development and evaluation of public health policies, programs, and practice. In terms of the scopes and objectives, the 2019 report use NHANES and provide national estimate of selected oral health outcomes across life stages, including dental caries, specifically coronal caries, dental sealants, edentulism, and tooth retention. It examined the outcomes in 2011 to 16 and change since 1999 to 2004. It also highlighted disparities by selected social demographic characteristics in 2011 to 16. And let's briefly discuss the method used in this report. So as we mentioned, we use enhanced data for two six-year periods, 1999 to 2004 and 2011 to 16. And the oral health assessment was based on the visual tactile examination conducted by trained and standardized dentists in a mobile examination unit. And to see the detailed enhanced oral health examination protocol, you can visit the enhanced website provided here to locate this document. And for this presentation, we will highlight select oral health measures in this report. Prevalence of untreated decay was defined as the percentage of dentate population with at least one tooth with untreated caries lesions. For children 2 to 8, we examined untreated decay in primary teeth. For children 6 to 19 and adults 20 years and older, we assessed untreated decay in permanent teeth. Prevalence of dental sealants was assessed for children 6 to 19, defined as percentage of children with dental sealant on at least one permanent tooth. For adults 20 years and older, we assessed the prevalence of edentulism, which is the percentage of adults with complete tooth loss or loss of 28 natural teeth. And tooth retention was measured as mean number of teeth retained among dentate adults with at least one tooth present. And oral health outcomes were measured by selected characteristics, including age, sex, race, ethnicity, and family income. For adults, measures by educational level and the cigarette smoking status were also examined. For findings we will present later, family income was classified as low income if less than 200% federal poverty level, or higher income if the income is 20%, 200% federal poverty level or higher. For analysis, this report presented age-standardized oral health estimates overall and by the selected characteristics. We use t-test to examine change in oral health measures between the two time periods and also the disparity by each characteristics in 2011 to 16, and the reported differences was statistically significant at p-value less than 0.05. So next, we will look at some key findings of this report based on the selected measures. So we'll first take a big picture across the life stages. And this slide shows untreated decay prevalence by age. So you can see data from 1999 to 2004 represented by blue bars, and data from 2011 to 16 presented by orange bars. And the chart on the left is for children. The chart on the right is for adults. The green arrow indicates significant decline from 1999 to 2004. So let's look at the finding for children. So we can see on the left, untreated decay prevalence declined in both primary and permanent teeth among children and also across age groups. For adults, however, the untreated decay prevalence did not show any detectable improvement among either working age or older adults. And also of note, if we look at 2011 to 16, working age adults tended to have the highest prevalence of untreated decay among all life stages. So next, we will examine each life stage. We will highlight prevalence of untreated decay and dental sealants, one of the most cost-effective interventions to prevent caries. So let's look at this slide. This slide shows untreated decay prevalence in primary teeth by race, ethnicity, and family income. The chart on the left is for young children aged 2 to 5, and the chart on the right is for children aged 6 to 8. So let's look at 2011 to 16, the orange bars. The prevalence of untreated decay is 10%. 10% for young children 2 to 5, and 16% for children 6 to 8, representing a decrease of 10 percentage points from 1999 to 2004. And even more encouraging, the decrease, as indicated with the green arrow, was across both race, ethnicity, and family incomes. Although the race, ethnicity, and income disparities remained, as indicated with the bold outlines around the orange bars, the greatest decreases tended to be among Mexican American children and the children from low-income families. And this slide shows overall prevalence of dental sealants and untreated decay in permanent teeth for children 6 to 11 on the left, and the children for older children 12 to 19 on the right. And in each chart, the two bars to the left represent dental sealant prevalence, and the two bars to the right represent untreated decay prevalence for the two time periods. And we can see the findings here are encouraging as well. For both age groups, dental sealant prevalence significantly increased to more than 40%, representing a 10 percentage point improvement since 1999 to 2004. And the increase in dental sealant was accompanied by a decrease in untreated decay in both age groups. And now let's take a closer look for age 6 to 11. And this slide shows prevalence of dental sealants and untreated decay by race ethnicity on the left and by income on the right for age 6 to 11. And we can see dental sealant prevalence did increase across race ethnicity groups. But the largest increase tended to be among Mexican American children, and correspondingly, Mexican American children also saw a significant decrease in untreated decay. Similarly, by income, only children from low-income households saw an increase in dental sealant prevalence and a decrease in the prevalence of untreated decay. And despite the improvement, the disparities by race, ethnicity, and income remained. And this slide just shows the prevalence of dental sealants and untreated decay by race, ethnicity, and by family income for older children 12 to 19. As you can see, the patterns are generally similar to what we just saw in the previous slide for young children. And next, we'll move to working age adults. And this chart shows untreated decay prevalence for working age adults aged 20 to 64. From left to the right, overall prevalence, then by race, ethnicity, family income, education, and finally by cigarette smoking status. So overall, more than 1 in 4 working age adults had untreated decay, and no change was detected overall or across the subgroups. However, current smokers experience a 5 percentage point increase in untreated decay prevalence from 1999 to 2004. Further persistent disparities remained. So roughly about 40 to 50% of working age adults who were non-Hispanic Black, Mexican American, with low income, with low education, and who were current smokers had untreated decay. So about 2 to 3 times the prevalence of their counterpart groups. And consistent with the downward trend in complete tooth loss or edentulism among adults observed in previous reports, from this slide we can see edentulism continued to decline to 2% overall in 2011 to 16. And the significant decreases were observed across most subgroups, except for Mexican American adults and current smokers. Disparities remained, particularly by income and current income educational level and cigarette smoking status. And next, we'll look at key findings in older adults. And this chart shows untreated decay prevalence for older adults who were 65 and older. So overall, about 1 in 6 older adults had untreated decay. And similar to the findings of working age adults, no change or no improvement were detected overall or across the subgroups, except for a significant decrease in untreated decay for the higher income group. And the notable disparities remained as well. For example, about 1 in 3 adults who were Mexican American with low education level and those who were current smokers had untreated decay. And consistent with the steady downward trend of complete tooth loss in older adults since 1950s, when the majority were edentate, edentulism continued to decline for older adults. In 2011 to 16, about 1 in 6 lost all their natural teeth, representing a 10 percentage point decrease since 1999 to 2004, and the decreases were across most subgroups, except for non-Hispanic Black older adults and the current smokers. Again, disparities remained pronounced. For example, among current smokers, nearly half had lost all their natural teeth, 3 times the prevalence in those who never smoked. And this chart shows the mean number of teeth retained among older adults. And overall, dentate older adults retained on average 21 teeth, an increase of 2 teeth since 1999 to 2004. However, no improvement was detected among those who were non-Hispanic Black, Mexican American, with low income, with low education, and those who were current smokers. And again, disparities remained. For example, non-Hispanic Black older adults and the current smokers had on average 16 teeth remained, compared with 22 teeth for those who were non-Hispanic white and those who never smoked. And the findings of this report we just presented suggest important public health implications. Over the last decade, oral health status has improved in children, particularly among children from low-income households. However, the improvement was not experienced among adults. And these findings are generally consistent with dental care policies implemented, which were primarily for the benefit of children, but limited for adults. So let's look at selected national policies and initiatives. For example, Medicaid is a joint federal and state public health insurance program for low-income populations. As we know, comprehensive dental coverage is mandatory for child enrollees in all states. However, dental benefit for adult enrollees is optional, determined by individual states. Most state Medicaid programs only provided limited or no dental coverage to adult enrollees. And as we know, Medicare provides health coverage for the elderly. However, traditional or original Medicare does not provide routine dental care. The Affordable Care Act, or ACA, passed in 2010 and became fully implemented in 2014. So under ACA, we know dental services are considered as essential and thus required health benefit, but only for children. For adults, however, no such provisions are specified. The ACA expanded Medicaid eligibility to include adults without dependent children, but at state's decision. So dental benefits are now covered for these populations in most of the states that provide Medicaid adult dental benefits and participating in Medicaid expansion under the ACA. But even with the expansion in 2017, only 16 state Medicaid programs provided extensive dental benefit for adult enrollees. In addition, several other national initiatives have been implemented since 2000. But again, most prioritizing children. For example, the 2009 Children's Health Insurance Program Reauthorization Act expanded dental care coverage for low-income children. The CMS Oral Health Initiative, launched in 2010, supported states in their efforts to improve the delivery of preventive dental services in children enrolled in Medicaid or CHIP. So what are the takeaway messages from this report? For children, we highlighted improvement in oral health status since 1999 to 2004, including the decrease in prevalence of untreated decay in both primary and permanent teeth, increase in prevalence of dental sealant on permanent teeth, and noted a greater improvement in Mexican American children and children from low-income households. However, disparities by race, ethnicity, and income remained. For example, for untreated decay in primary teeth by age 6 to 8, about 1 in 5 of those who were non-Hispanic Black, Mexican American, and the children the prevalence of their counterpart groups. Similarly, by age 12 to 19, still about 1 in 5 of those children had untreated decay among children from low-income household, which doubled the prevalence of children from higher income households. Prevalence of edentulism or complete tooth loss decreased, and the number of teeth retained increased. Untreated decay remained prevalent. About 1 in 4 working age adults and 1 in 6 older adults had untreated decay, particularly with no change or no improvement since 1999 to 2004. And alarming disparities by race, ethnicity, income, education level, and smoking status persisted. For working age adults, about 40 to 50% had untreated decay among those who were non-Hispanic Black or Mexican American with low income, low education, or those who were current smokers. For older adults, for example, half of current smokers had lost all their natural teeth. So in terms of the public health implications, overall, the children's oral health, the improvement in children's oral health status was not experienced among either working age or older adults. And this finding is consistent with policies implemented between the surveys. And more importantly, the aging population and the improved tooth retention also mean that more adults are at risk for dental diseases, which may present challenges to healthcare and public health and the dental public health systems. And at the end, but most important to note, this report relies on a large group of my CDC colleagues' collective and tireless efforts to contribute to and review this report and the presentation. Just to name a few, my colleagues who contributed to the development of this report are Dr. Susan Griffin, Dr. Barbara Gooch, Dr. Lorena Espinoza, Mr. Liang Wei, Mr. Charles Lee, Dr. Gina Thornton Evans, Dr. Michelle Newberger, Dr. Valerie Robinson, Dr. Eleanor Fleming, and Dr. Eugenio Beltran. And this report was reviewed by Dr. Cassandra Stewart, Ms. Nicole Johnson, Mr. Casey Hannon, and Ms. Cassie Brailer. And I also want to thank my colleagues, Ms. Cassie Brailer and Mr. Chris Callahan for kindly facilitating this webinar and providing all the technical support. And before I wrap up, there's one final resource I would like to tell you about. CDC has created a variety of infographics displaying the data and the trends from this 2019 Oral Health Surveillance Report. The examples I have here and many more can be accessed with the URL provided here. So that's all about my presentation. Thank you everyone for your attention and the time. With that, I'll turn it back to Dr. Gina Thornton-Evan.
Thank you, Dr. Lin. We really appreciate your time and effort to putting this together. And we also want to thank all of the individuals that participated today in this webinar. And we will be providing information about the actual presentation in the future with respect to the slides. I see one comment in the chat so far about the hyperlink, and so we'll definitely provide that as well. Before we get into more specific Q&A, I just wanted to mention that our next speaker will be Dr. Natalia Chalmers, and she will present roughly in May. And as most of you may know, she is serving as a dental officer in the CMS program, and she's going to be talking a little bit about approaches to achieve better health and equity. And that's right now scheduled for May 12th. Following her presentation later in the fall, we'll have Dr. Fred Hyman from the FDA that will do a presentation. So if anyone has a question that they would like to pose, I would encourage you to put it in the chat box if you would like. And if there's someone that would like to ask a question verbally, please unmute yourself, and state your name and then the question as it's directed to Dr. Lin. We'll wait a few minutes for some questions, but Dr. Lin, could you just give a brief synopsis again about what these findings really indicate? You alluded to it in terms of the policies and such, but how do you think that we may, improve in the future with the working age adults as well as the older adults?
Yes, thank you, Dr. Gina Thornton Evans, for this great comments. Yeah, as we presented for this report, you can see our health status has improved, particularly for children, but for adults, we kind of did not see the same improvement. There could be many promising, there could be kind of several promising kind of strategies that we could explore to improve our health status among adults, and particularly for working age adults. As we mentioned, the current dental care policies kind of limited, quite limited for adults. And one potential strategies could be kind of to do some kind of the current efforts in medical setting, especially the medical dental integration, because the medical settings may present missed opportunities and could be promising venues to provide adult oral health education and other services, because we know, especially for adults, they are more likely to visit medical providers than visiting dentists. And we also know adults tend to have higher prevalence of one or multiple chronic conditions. So the medical setting, or integrating the medical and the dental settings to provide some shared services could kind of to present promising kind of strategies to improve not just our health, but general health status of adults. And another strategies could be through expanding dental safety net for adults. So that may be a potential approach, because we have seen some studies showing that introducing dental benefit for low-income adults in states where the Medicaid did not cover comprehensive dental benefit, so that explored that strategies may improve both dental care use and their oral health status. So yeah, there could be many strategies we could explore.
Yes, thanks, Dr. Lin. And I know that the Division of Oral Health has been working on getting external stakeholders engaged with respect to medical dental integration. And so it definitely is a really opportune time to really focus on that and how we can align ourselves more so with medical providers. Definitely an opportunity to enhance or to improve care related to dental. If there's not any additional questions,
I have one question.
okay, yes, Dr. Parker.
Hi, well, Dr. Mei Lin, thank you so much for this presentation today. The question that I have is, as it's evident that for adults that we're lagging behind in improvement, what are your thoughts on what this data may look like with COVID-19 in the years to come in terms of, you know, given the subpopulation and what we're seeing now? What are your thoughts on the impact of COVID and the data that we'll be looking at in a couple of years?
Yeah, thank you, Dr. Parker, for your comments. And I think the impact on the adult population, especially like during the pandemic, and maybe also carried over during the post-pandemic period, because as we kind of mentioned, adults tend to have higher prevalence of chronic conditions such as diabetes and heart disease. And those conditions are also kind of risk factors for the COVID-19 infection. And we also know like minority population and those with kind of a lower income, they also are vulnerable to the COVID-19 infection. And with considering all these kind of factors, we would think we do need to kind of to revisit what we could do and what would be the effective strategies we could help improve the oral health and also the general health status of the adult population, and especially those with social economics disadvantage state.
Yes, thank you, Dr. Parker, for that question, and Dr. Lin for your response. And I think one thing that I would like to share with the participants is that the Division of Oral Health is really moving forward to actually collecting some information, utilizing NHANES in a modified protocol. Their plan right now is they've actually ceased all operations, but they are planning on going out in the field this year. Probably full implementation by April or May. And a lot of that is contingent on the pandemic, as you all might know. But we do have an opportunity to ask a set of questions that will focus on quality of life. And they'll be asked of individuals 1 year and older. So hopefully we'll be able to get some really good information about how COVID has impacted individuals, and especially for that working age population and potentially older adults. But obviously the sampling is going to be a little bit different because of the pandemic. So once again, I would like to thank everyone for participating today and want to acknowledge Ms. Brailer and Mr. Callahan for their work to getting this together. It's a lot of times very challenging with respect to the technology. So I really appreciate all their effort with respect to getting this together. And please look out for messages soon with respect to our next presenter, Dr. Natalia Chalmers, in May. And then that's going to be followed with Dr. Fred Hyman of FDA in the late summer, early fall. So once again, thank you all very much. And I appreciate Dr. Lin for her excellent presentation today. Thank you and have a good day.
Thank you.